morning. Actually, there are different time zones that are involved in this moment, and thank you very much for attending our webinar on biomedical robotics in the day when we are celebrating the biodiversity. In this case, we are going to celebrate the biorobotic diversity, we could say, because there are so many types of applications that our speakers are going to introduce today. So it's better we start immediately with the first speaker, which should be Letizia Gianfrida, representing the King's College London. Thank you, Letizia. The stage is yours.
Perfect. Can you all see my screen?
Yes, we can, yeah.
And can you hear me fine?
Yeah.
Yep.
Perfect. So hello, everybody. Today I want to talk about human-centered physical AI for adaptive human-robot interaction. My name is Letizia, and I'm a lecturer in computer and robot vision in the Department of Informatics at King's College London. Before we start, I thought about giving a very brief introduction about myself. I completed my bachelor and master's degree from University of Naples, Federico II in bioengineering. I then worked as a researcher at Nanyang Technological University of Singapore before doing my PhD in post estimation at Imperial College London. During that time, I founded a company, a digital health company, raised around 1.2 million, then exited the company and started working as postdoctoral fellow at Harvard University, where I currently maintain kept an active affiliation. I am the associate co-chair of the IEEE Technical Committee, RAS Technical Committee on Computer and Robot Vision. And since my time at King's SPI, my team has been growing and we've been quite successful in funding. So what I wanted to do today is to describe a bit more about what we do in the lab. The lab is called the Vision Human Robotics Lab, and we look at human-centered physical AI for adapting human-robot interaction. We look at specifically how we can take continuous human sensing, biomechanical modeling, and derive tailored actuation and control strategies for better collaboration between human and machines, essentially. The lab unfolds around 3 pillars, and what I want to do today is to go through these 3 pillars and to describe them in potential details, in the sense that I will provide potential, like if time allows, an example for each one of them. Starting with the VHR sense, where the aim is to estimate human state outside laboratory settings. So we look at kinematics with using marker-based optoelectronic motion capture system or markerless. Cameras, we look at residual muscle activation, muscle activity, muscle deformation using surface imaging and ultrasound, and we clearly look at robot state to understand human intent and robotic response. To give an example of a study that I conducted on the topic, I worked on using B-mode ultrasound to understand muscle state. So unlike surface EMG, which essentially capture proxies of muscle intent, B-mode ultrasound provides a direct access to internal muscle contractions, muscle dynamics. And if we look at something similar to a linear spring model, we can describe the muscle force as a function of the stiffness, the fascicle length, and the pennation angle. Now, fascicle length and pennation angle can be obtained from the ultrasound itself, but clearly stiffness is not the case. So to obtain the stiffness, we conducted a biomechanical characterization during isokinetic dynamometry to obtain joint torque that was then approximated to muscle force. And that's then was evaluated on younger older adults working on a treadmill at different speeds, showing essentially the performance of the tracking of the fascicle length and pennation angles in real time using an ML-based tracking system. Overall, these are some of the results. We have users walking at different speeds, a different incline and decline as well. And we got a root mean square error overall below 4 millimeters between the ML-based fascicle tracking and the manually derived ground truth that we looked at the time. Another example that I want to give about something that we do in the lab is around the VHR model. So we look at modeling human state, and this is really when we aim to bridge a gap between the sensing and the control part. Specifically, what we do in the modeling part, the modeling framework is split into these two parts. So there is like the traditional inverse kinematics approach, where you have physics-based state estimation of kinematics, muscle dynamics, internal joint angle, muscle forces, body states, and you have like also, we can also look at it from a forward dynamics perspective with the muscle-driven simulation like MyoSeed to train control policies that map estimated human state to robot actions and internal forces. We have something like an optimizers, classic optimizer block, where we have the optimal control that is given by the human state XT and the robot state UT, where in input, where we want essentially like minimize the user's physical state and robot state. And we have the traditional kind of like safety constraint in order to obtain the U star that we want to obtain. To give an example of a study that was conducted by a student in my lab, Eric, and was presented last year at the International Conference of Robotic Rehabilitation, ICOR. We looked at a wearable robotic controller that was optimized to compensate for underlying muscle dynamic deficits. So we looked at essentially collecting video data from users manipulating different YCP objects, extracted kinematics, derived muscle dynamics. Then we looked at decreasing the muscle dynamics to a level of similar to sarcopenia, and then we looked at how the exoskeleton could compensate for those deficits. Overall, in results, we got that video does improve training. So we have like the training timestamps where we show essentially that video demo prior and without video demo prior. But we also have the healthy agent and compared to kind of like the weakened hand and the exo glove on the weakened hand that is trying to bring the weakened hand back to the healthy agent baseline. A very last example that I want to give is more on the robotic front. So we collect this data, we model this data, and we model the actuation side, but then how do we really actuate these robots? And this is kind of like the third pillar of the lab, and the core philosophy here is a human-in-the-loop optimization system, where we take biological sensing, like what I've described before, surface EMG, ultrasound, kinematics, and we really use them to shape the interaction between human and robot across different domains, really. Healthcare, we have been looking at personalized assistance in wearable robotics, prosthesis and exoskeletons, or in assistive robotics, but also this can be applied to industrial and manufacturing settings to really understand adaptive shared autonomy and assistance in manipulation and locomotion tasks. This is an example of a study that a member of the team, Teron, has been presented at TAROS, which is a UK robotics conference. He got Best Paper Award for that. But we have also presented some part of this work to RAL, Biorob, and other venues. The overall idea is that you have like this soft exoskeleton that is based on a tender stealth mechanism that is driven by a servo motor and is controlled by an Arduino microcontroller. And what we wanted to check was whether intent was better derived from a controller like push button, tactile, or vision. And here in the graph, the darker blue indicates higher capabilities, while the yellow indicates lower capabilities of the system. So we showed essentially that the system works with healthy and across different control modalities, really. And currently, we're doing quality management system implementation towards CE marking. And we're working towards MHRA. For those who don't know what MHRA is the Medicines and Healthcare Product Regulatory Agency, as we are doing our tests on different people with populations with mobility impairments, such as post-stroke survivors. Another study that is ongoing in my lab, and this is kind of like a very brief review of a study that is instead of that Eugenia has been working on, a PhD student. She has been looking at ecocentric manipulation of nurses in operating room and how we can use learning from demonstrations to to essentially support the learning of the robot in identifying and opening this sterile packaging during surgical procedure. This is an ongoing work, but part of this work will be presented at BioRob this year. Before I conclude, I just wanted to really thank the entire team. I've been very, very lucky to meet these amazing people I had the privilege to work with. I want to thank the founder and all our collaborators. And I'm happy to take any question if time allows. Thank you.
Amazing. Thank you very much, Letizia. That was very interesting. I'd say we can open questions to both the panel and the chat, so feel free to ask questions, but we'll start with one quick question from myself and then see if there's anything else from the chat. So yeah, thank you very much again. I can see there's, especially for the first two use cases that you've sort of showcased, I can see there could be a lot of use case and applications. My question is, can you expand on that a little bit? Like, have you got a specific sort of hand impairment or disability that your project can help, or is it just more generic? And have you done studies with with real people?
Yes. So far we've been funded to conduct two studies that are currently ongoing in the lab that I have not presented because are really preliminary at this stage. But we've been working with rheumatoid arthritis patients, and we've been working with post-stroke patients. And actually, we've been working on a very high level also with motor neuron disease patients. The end goal is very different. And what we are doing currently is to have, we've been having PPI meetings to look at the user requirements. How do the user interface with advice? What is the overarching goal of the device, and how the device should communicate with both the carer and the provider? And yes, that's why we're going through QMS and MHRA towards like CE marking. We are aiming to finalize a cross-sectional diagnostic study that we are doing in the lab that is going to be more towards like sim to real, where we are like looking at like a control that is implemented in simulation and for it's an adaptive control strategy based on underlying muscle dynamics, we are aiming to conclude that by October, and then to move on to a longitudinal study next year.
Okay.
Specifically for stroke survivors.
Okay, good. Thank you very much. Have we got time for another one? Oh, Andrew. I think Andrew's got a question. Yeah. Andy.
Please call me Andy Gianmarco. It freaks me out.
Sorry, I just saw the chat, just saw the first name.
That's all right, no worries. Letizia, thank you so much for the presentation. Fascinating. As somebody currently going through medical regulations, how are you finding ISO 13485?
Long and tedious, very informative, very, very informative. I think, for instance, yesterday we had our risk assessment kind of like a training. And what I realized that personally, with my background as an engineer, we as engineers, as bioengineers, we don't always get trained to build a device that look at end users' requirement, like putting together alerts or like things that are so, simple, that not really require an extremely complicated technical, challenge to solve, but are still very, very useful for end users. And I think like going through that process is letting us realize that, of course, like the underlying tech needs to be very, very solid, but there are also a lot of things that need to be taken into account, around cleaning the device and keeping the device safe, and all things that need to be considered that are quite important to make a product sustainable and to make it into a product that provider want to prescribe to end users.
So thank you very much. And if you need someone working on the ISO standard 62366 on usability engineering on medical devices, just let me know. Let's move to the second guest, Danny Oetomo from the University of Melbourne. Danny, please. Thank you.
Thanks, Jacinto. I'll ask my questions later. Okay. Okay. Good day or good evening in my case. Good day to everybody else. Thank you for having me. My name is Denny Utomo. I'm from the University of Melbourne. Very happy to be here. I'll just do a very quick introduction of our work. We work in physical human-robot interaction. Most of our work is applied to three broad areas of applications. We've got probably the oldest one, which is rehabilitation robotics, which is we're going to talk about tonight. I also have the group has also an area in advanced prosthetics, which has been going on since 2014, and we've been quite fortunate, and that's probably about 40% of our work. And we have the most recent one is application in the area of industrial assistive robotics. One of them is the sheep shearing application for people, with sheep shearers and their lower back injuries. We've been working with the Australian Wool Innovation since 2019, perhaps. And of course, it's Australia, so we have to have sheep shearing in our projects, right? And rehabilitation robotics is what I chose to talk about tonight. Just a quick summary of the history. We started working in human motor adaptation probably in 2012. We were very fortunate that the university was able to afford a Hokoma Army of Power for us to play with in 2013. In 2016, we started building one ourselves. The first one's made out of wood, and we were also, again, quite fortunate that it went through the entire process of IP and technology transfer, and it's now a commercial product that has received EU MDR and FDA, and it's used in a few places. Just a quick illustration of how we look at rehabilitation robotics. This is from the angle of the robot that we design and produce. This is how we envisage it at the beginning. If you see it today, these robots in a commercial sense would come with a big screen and has games in front of it, and you simply play the game with the robot. But this is how we actually envisage how it's used. We didn't put a handle initially, so we actually took off the handle from the commercial unit that we got, and we put it back to the original way we designed it for. The patient is strapped in pretty quickly, and then you can do a lot of things. Basically, the rest of it, it's in the robot and it's in the software. You can write a lot of assistive algorithms to it. We have different control modes, and the therapist can set the controller on the touch screen that we install at the back. So that's not part of the commercial setup. And the idea is for the robot to act as a assistant to the clinician and perform a lot of the traditional and technique that we have known and that they are very familiar with in such a way that there is a high level of acceptance, technological acceptance, because we are not forcing them to do anything drastically different from what they are used to. And again, this is implemented in the way that we wanted it, so it can interact physically with the object, providing all the haptic, tactile feedback and everything else that the clinician intended. Well, you get the idea, right? And then I got Jacinto's and Andy's and everybody's invitation to do this 10-minute talk. I'm like, oh my God, 10 minutes. That's such a I don't know what to say for 10 minutes. It's so I thought I have to say something semi-intelligent this time. So I decided to pick a specific topic. I said expectation of rehabilitation robotics. There's a bit of an issue, well, a bit of a conundrum, I suppose, here, because there is a lot of mismatch in expectation, not just in rehabilitation robotics, but robotics in general. Hollywood does a very good job of messing that up for us, right? They show all these futuristic robots, and when the public looks at our robot, they go, "Oh, is that all it can do?" They have all these expectations, and similar things happens to rehabilitation robotics as a field, and perhaps the sentiment is best summarized in this paper, Rattles, published in 2019, led out of the UK, actually. And the summary, and I'm paraphrasing here, it's a long paper, big paper. It was a massive summary of massive amount of trials that it is not the silver bullet that we all expected it to be. I think there's a lot of expectation that you simply pop the patient into the machine, press the button, and they come out cured, but that's not the case. It noted that it has a lot of improvement in impairment measures, and but there is limited translation to daily functional outcomes, although they found that there is the outcome roughly is no worse than conventional therapy acceptable, but because you still need to have the robot, and the clinician is not really cost effective, and so on. So there's a lot of very important nuances in that paper. But nonetheless, there is a sense of, oh, it didn't really quite do what we wanted it to do, you know. But to me, there's a lot of it that is just, you know, due to setting the wrong expectation from the start. It's not the silver bullet, yes, but there's various factors still to consider, including how much we know about how the brain works and how to deal with it, you know. So there's a fair bit of that as well, and I think our knowledge would continue to improve as we work on better technologies for measurements and assistance. So if we can't expect a silver bullet, then what can we expect? So how about something that you know, if I believe if we ask the right questions, then there's a lot that robots can offer in making advances in those directions, right? So how about improving dosage? Dosage is the amount of repetition that we do in rehabilitation in the therapy session. This is the traditional reason of robots making its way into industrial automation anyway. It's to improve productivity. So why not? You know, every paper has ever been written in rehab robotics always says, oh, you know, we don't have enough clinical expertise to go around, and therefore here it is, right? So we ran a study with 10 patients, 10 participants, sorry, not too many. And we found that we could reach around about 200 repetition, quality repetition in one therapy session of 45 minutes. And that compares to about 36 to 57 in the traditional conventional therapy. And there is one study that reached about 800 repetition per sessions, but that's a bit of a different setting. So it does do that. It can do that. Can it modulate cognitive load during therapy? Well, cognitive load, by the way, is important because we need cognitive engagement during therapy. So we don't want the patient to simply just switch off and let somebody massage and move their arms around. They need to be, you know, they say what fires together, wires together. So they need to be aware and be engaged in the therapy. And we won't talk about the one on the left because, you know, because of time, but the cognitive load on the right, you can read it as cognitive engagement. It shows that when the robotic assistance is high, the cognitive load is low, and when we assist less, the person is engaged more. So it gives us a way to modulate cognitive engagement in therapy, which is good. That's another thing we can use to improve the efficacy of our session. Can we modulate task difficulty? When patients get better, you need to make it a little bit more difficult. Most literature, there's a lot of literature on this, there is this thing called assist as needed, and there are lots of papers in there. Most of them are control theory, adaptive controllers and all that. Fantastic work. But I want to do something like, if that person improved by 10%, how do we make this task 10% more difficult? Something quantitative. So I said, oh, we looked at, well, the answer was right there all along in Fitz's law, steering law, all the variants of these laws that have been introduced and well tested. And it basically just says index of difficulty is a function of the target size and how far you have to reach in the reaching motion. Very simple. And the performance, MT, is movement time, is how long an individual takes to perform a task of such difficulty. Right, so we run a quick experiment. We just have 4 settings, low, medium, and high. The 2 middle settings are of the same difficulty because the target is smaller, but the distance shorter. And voila, it came out like this, you know, Fitz's law. And, you know, it's a law, but it's been studied and proven. But when it when you run an experiment, it comes out like this, it's still like, wow, that's beautiful. I can't believe it works, you know? So here it is. The lowest difficulty scored the lowest movement time, the medium scored about the same, the 2 sets, and the highest difficulty scored the highest time. And when we put robotic assistance, we could then change the performance of individuals according to how much we put in. And that gives us another way to modulate task difficulty when you perform the therapy in collaboration with the robot. Last one. Learning from demonstration. Letitia has already covered that briefly as well. When a robot arrives from the manufacturers, it comes with set programs, it can do all these things, but then, you know, along comes a patient and the therapist go, oh, I wish I could just write this program that can do this, just, you know, to just support the patient's arm to reach for the red blocks and put in a red box or something. Yeah. But you call up the manufacturer and say, can you write this program? Go, oh, no, that's too difficult, too hard. But how about getting the therapist to program the robot themselves? Would that be possible? Well, to start with, the therapists don't want to. If you ask them, do you want to program the robot? They go, no, I don't want to write code. But then you go, how about you just show the robot what you want it to do, right? Like training a dog, and therapist typically go, oh, dogs I can train. Yeah, okay, we could do that. So learning from demonstration, as mentioned earlier, is simply telling a robot what to do, and from very few demonstration, unlike reinforcement learning where you need lots and lots of sample data points. In a way, we ran a quick experiment to show the robot what we want it to do. Generally, it captures what we want it to do. So we use TPGMM, task parameterized Gaussian mixture model. That seems to work pretty well. We also are moving into recreating the force profile of the assistants as well. Beyond that, we also want to look at movement quality. We say, well, you know, therapy is not just about performing the movement, picking up a block to move to another location, but you also want, you know, therapists want it done in good posture and it want it to be smooth. You know, a lot of patients have compensatory motion in their movement. All that, it seems that we are able to capture it with the right algorithm. Here we have 2 measures, jerk, which shows the smoothness, and manipulability, that shows the posture. And we do get a good correlation between the rollout, the movement that the robot performed compared to what we want it to do. Yeah, so I'll stop there with a few takeaway points that I think we get what we ask for. So if we want to design a rehabilitation robot, I think we need to do it with a clear question in mind of what we want the robot to do, and therefore engagement with the therapist and the actual needs is very, very important. And robots can provide answers to well-posed questions, such as in this talk, I just covered a few examples. So I'll stop there and I'll take questions.
Amazing. Thank you very much, Danny. As usual, we'll open the question to the panel and to the chat as well. I'm really forcing myself not to ask loads of questions about working with sheep because I really want to know how that was. But from a more technical point of view, and then I'll go back to Andy. So you've mentioned, which is quite impressive, it was nice to see your journey from sort of 2012, I think, up to nowadays when you managed to get MDR and FDA approval for your prototype. Can you share a bit more about that journey? Because that's one thing that most of people in this field struggle with, I'm aware of, and it's sometimes harder than the actual technical part of the project.
Yeah, I was fortunate that we work with an industry partner. So I don't know. Well, so they also have a department that is much better equipped to do that. Along the way, you get to know a little bit more. So in terms of obviously the requirements on the quality management side, most of it is taken care of by, of course, the manufacturer themselves, because they're the ones who need to provide the certification for that. And since I'm not the manufacturer, I don't have to deal with that part. But then a lot of the work that we did also supply a lot of the clinical evidence and usability studies and all that. That's sort of formed the groundwork of the paperwork as well. There is also a lot of, I guess, know-how in this community, and I think engaging the right consultants, they know how to, you know, there's a lot of precedents that can be brought up to demonstrate that your device does pretty much the same as that, only a little bit more, and in that way that tends to provide you with a lot of shortcuts, not shortcut, I suppose. It's already demonstrated. Certain part, a big chunk of it has already been demonstrated by somebody else. Yeah. Yeah,
Okay.
maybe. Yeah, I'm not an expert myself, so I wouldn't.
Okay. Okay.
Yeah,
I think no one is when it comes to that. Andy.
Thanks very much, Gianmarco. Denny, wonderful talk. Thanks very much. Really great to see you again. Not so much a question as observation. Just you mentioned the Rattler study, and that the Rattler study in the UK is actually quite controversial, depending on who you ask. So a couple of the kind of criticisms thrown at it are, it was mainly around severe arm impairment, so people with kind of chronic stroke post 1 year, which is probably difficult, and it wasn't in people who had more milder impairment where you might have seen a bigger benefit. And on the kind of healthcare economic side of things, the kind of criticism thrown at it is that the MIT Manus is a wonderful piece of technology, maybe not the most cost effective. And we're probably, I mean, how many decades are we after that study, and how things have kind of probably come down in price, and the increase in the number of robotic systems that are available for upper limb therapy. So I think it's an important study. I think things have moved on. My own feeling really was it was probably a really early time in this technology's development to do such a trial, and an assessment. And I'd be very interested in a repeat of that now, where we are today with other types of technology. I don't know what you think.
Yeah, I agree. I mean, I was at 2019. I was at Rehab Week. That year was Rehab Week when it was released, and I was there, and there was a fair bit of, like you pointed out. I think a lot of people felt it could be detrimental to the field and all that. I mean, I read it from cover to cover. I think it's a good paper. It forces us to think about it, and I think it needed to be there. It serves its purpose. I guess you can take it one way or the other. But yeah, same reason why I chose it for this talk, I suppose. It captures the sentiment. There is this, that argument that it didn't quite live up to expectation in a way. But yeah, maybe we take it as the reason to work harder.
Yeah. Thanks, Denny.
Thanks, Andy.
Okay, we've got a quick question from the chat, and I think we'll have to move on after that.
Yeah.
So Don from Ravasek asks, Danny, was wonderful presentation.
Yeah.
My question is about the safety aspect of the robotics as utilized in your study and prototype. Did you think about those fail-safe procedures or algorithm, perhaps?
Yeah, that's a big part of it. That's definitely so. The whole system was designed. The IP for that system was on the way it is used, and we designed it with a very backdrivable mechanism, which is very much like a traditional haptic devices. We do think about the safety procedure a lot. Even after that device was produced, years later, we still have, in recent years, I mean like maybe 3 years ago, we published a paper more on the control safety aspect as well. published in TRO, where it was more focused on admittance device, because admittance device is more powered, more powerful, I suppose, because by default it does not move until you tell it to. So it generally it's a more powerful device. Yeah, I think it is something that we still continue to work on until today. Yeah. We that paper we looked at instability, and if we detect the onset of instability, we actually put a different controller to sort of damp out the system, and so we compare it to some recent work as well in this area.
Cool. Thank you very much, Danny. Jacinto.
Thank you.
Thank you very much. Thank you very much for the questions. All these topics related to the safety, the workload, the engagement are making me feel really comfortable, actually, because I work in ergonomics of medical devices again. And let's move to the third speaker, Veronica Magdans from the University of Waterloo in Canada. Thank you very much, Veronica.
Thank you for having me, and thanks for the invitation. We're going to shift gears now and go down quite a few scales. If this works, yep. So we work on medical robots as well, but they are small scale. And with that, they're usually in the micro or millimeter range. And why do we do that, or what's the purpose of these? So these are quite different from the large robots we have seen in the previous talks. And how we define these micro or small scale robots is that they have autonomous motion. Because they're so small, they need some sort of onboard power source or some external fields that move them in an autonomous way. Of course, we need to remotely control them, so we know where they are and where they're going. And of course, they're only robots if they can perform certain tasks. And the ones we are particularly interested in is to perform very targeted and localized cell and drug delivery inside the human body, being able to manipulate single cells, perform minimally invasive surgery, or do diagnostics. And you can imagine that that this is not just an engineering task, but we really have to think about the whole process, and it's very interdisciplinary as we develop these small-scale robots. Because as we design and choose the materials of these small robots, we already have to think about how we're going to actuate them, how we're going to control them, image them, how can they cross certain barriers. Let's say we want to cross the blood-brain barrier or some mucus inside the body. How can we do that? How can they perform the medical tasks? And how do we get them safely inside the body and out of the body again? There we go. So I've been working with microrobots for about 15 years now, and we started first working with catalytic microjets, so small tubes that are on the micron scale that are driven by chemical reactions. Then later we started using motile sperm cells to power these microrobots, and also developing shape-changing materials that can move like biomimetic robots, like these jellyfish. Then we continue to work with sperm templated microrobots that are magnetic. And now recently we work more and more with bio-inspired robots, like this small filament you can see here that has an embedded micromagnet, and we can use external rotating fields to drive these filaments forward, for example, inside the urinary tract or other parts of the body. The idea is, again, that we can use these to perform non-invasive surgery or deliver drugs in a very localized way. And today I want to point out just 3 areas that we work in. On the one side, we do localized drug delivery with these wireless robots, such as cancer drug delivery, delivery of antibiotics or thrombolytics, but also to perform surgery, so to remove occlusions like blood clots or kidney stones that would usually require surgery. So let me show you this first so-called biohybrid or sperm templated microbot, where we use bovine sperm cells and cover them with magnetic nanoparticles, and then we can use a device that creates rotating magnetic field to drive these single sperm cells. So here, what you see in the video is a cell that is non-motile, but because of the response to the external rotating field, we can then have full control over the motion of these cells, and they move actually quite similar to live sperm, but this is completely controlled by the rotating magnetic fields. So we not only showed that we can have precise control over their motion, but we can also load them with anti-cancer drugs, or we can create these clusters of sperm cells with magnetic nanoparticles, which are then shown here in these very bright red images here. These are the drug-loaded cells. And thanks to the magnetic particles, we also get a very good signal-to-noise ratio, so a good signal in ultrasound imaging as well. So it's the first time that we are able to image sperm clusters inside reproductive tract models. And now I will briefly talk about these bio-inspired robots. So here we have these small filaments that we designed to move in the urinary tract to target kidney stones. And here you can see some of the design criteria. So we choose our materials to be biocompatible, to be able, so in terms of the design and size of them, to navigate through the urethra into the pelvis. And we want to load an enzyme into these robots that will then catalyze the reaction to increase the pH, which is one of the therapeutic approaches to dissolve uric acid kidney stones. So that's what you can see here. We designed these small robots to contain this enzyme, and it was successfully dissolving uric acid kidney stones much, much faster than we would usually see by consistently changing the pH in the urine of this model system. So this was our first demonstration of doing a non-invasive kidney stone dissolution with the help of these small robots. But of course, this is only done in vitro so far, so there's still lots of things we need to test. When we look at the performance in these ultrasound phantoms, we can see that we get a good signal in ultrasound. Let me just see if I can play this video here. There we go. So thanks to the motion of the robot, we can get good signal in ultrasound in the Doppler mode, but also the micromagnet helps to give us good echogenicity. So this is very promising. We work with clinicians now to bring this further and to develop the technology in a way that it can enter the clinics. One last application I want to point out is for the removal of blood clots. Here we use a slightly different design. So we want to have a wireless robot that is able to disrupt the blood clot and perform some mechanical force on the clot. So we designed these small helical, almost screw-like structures, again, that we move with rotating magnetic fields at low frequencies. And then we can show that we can introduce them in an ex vivo model of the sheep, and we can move these helical robots successfully inside the blood vessels and also image them in real time, which of course is very important to track and to localize the robots during their performance. And that is everything I wanted to share with you today. And of course, I'm not doing this alone, but with a fantastic team of students, but also collaborators here at the University of Waterloo. So thanks so much for your attention, and I'm happy to take questions.
Brilliant. Thank you very much, Veronica. Very interesting. And I like that sheep were mentioned again. So I've got a couple of questions actually, and like as usual, anyone else feel free to ask questions on the chat or on the panel. So I'm always quite fascinated when it comes to sort of micro scales, because it's something that I'm completely not familiar with, completely new to me. When you were showing the picture of the sort of sperm cell that was completely covered with the microparticle of the magnetic microparticle, how are they added? Like, because we're talking about 1/100th, it looks like 1/100th of the side of the sperm cell, which is already tiny. How can you be so accurate, and how do you deposit them onto the sperm cell that accurately?
Yeah, good question. So it's hard to really place them in a directed way, but what we know is that the sperm cells have overall a negative surface charge, and the particles have a positive surface charge. So there's simply electrostatic interaction that binds the particles. And we did a whole study on looking at how they move when the particles are deposited on different areas. But the truth is that right now it's not controlled. Okay, we incubate the particles with the cells. They bind wherever they bind, and then we look at how they move and select the ones that move well, because we don't have control over the membrane charge in certain areas of the sperm. So it's just self-assembly, yeah, that we take advantage of at the moment.
Okay, yeah, thank you. That solves the mystery. Yeah, Andy.
Thanks so much, Veronica. Wonderful talk. Thanks very much. Probably a little bit my ignorance more than anything else, but just wondering about your kidney stones and your use of ultrasound guided. Is this 2D ultrasound or 3D or 4D, and how exactly does it work when you're trying to move in a 3-dimensional space, but you've got a 2-dimensional image and you want to bring two things together? That sounds like a really tricky thing. I welcome your explanation of that.
That's very, very right. That's one thing we're working on right now. So far, the experiments you saw and what we've published is with a 2D ultrasound probe. And now we're working on using two probes and setting it up in a way that you can get the 3D location, so the location of the robot in the 3D space. And then the idea is to integrate that and give feedback to the actuation system of the magnetic control system, so that we have everything in one. Yeah, you have let's say a 3D picture of the organ or the whole human body, and then also where the robot is and where it has to go. Certainly is a challenge, and this is one of the things, let's say, on the robotics and engineering side that we're working on now.
Yeah, fascinating. I don't know if you're attending UKRAS, but an opportunity for us to plug our UKRAS, Canadian Robotics Council meetup on the Tuesday evening. But if you're attending, Veronica, it'd be wonderful to chat to you. I have an application that's kind of a similar challenge, so it'd be great to compare notes at some point.
I'd be happy. Yeah, that would be fantastic to talk about that, because it's a bit outside our expertise. Let's say we're building up on that, but we'd be very happy to have input on that. Yeah, let's chat.
Brilliant.
Okay.
Just as a reminder of what Andy said, that event, the sort of Canadian and UK cross meeting will happen on the Tuesday of the UKRAS event, starting from 6 or 7. I can't remember now. So yeah, if people want to join, please feel free to. Yeah, Jacinto, do you want to open the panel discussion?
Yeah, and let's cross fingers. We are going to discuss in Vienna exactly for this event. So I want to connect to the questions actually you asked, Gianmarco, and the one of Andrew, because both of you highlighted this peculiarity in terms of scale of the work of Veronica. And this question actually is for all speakers. You represented different levels of the scale of the biological systems, and you extended that also to the actual world and the actual experience of the users. We even stretched the topic towards the regulatory aspects. So this is matter of interdisciplinarity, cross-disciplinarity, multidisciplinarity, and transdisciplinarity. Let's say you're forced to go beyond the disciplinary boundaries, and robotics is already intrinsically an interdisciplinary domain, biorobotics and biomedical robotics even more. I want to ask you, just for starting this round of questions, because we have 9 minutes, if we can quickly tell us the main challenges of collaborating or even fighting with experts from other domains. They could be students you hired, PhD students you hired for working on certain aspects of your projects, or it could be clinical stakeholders. And with clinical stakeholders, please try to remember that we have also the patients. The etymology of clinic means that we are really close to the bed of the patient. So any kind of challenge you can find in your own domain of application, and possibly try to refer also to the opportunities for expanding the unmet needs, the solution for the unmet needs you found, possibly in collaboration with British partners. Thank you. We can start with Letizia. Letizia, you're already in the UK, so you already know the British context. Then Danny, and then Veronica. Thank you.
So what I'm finding in the British ecosystem, according to, of course, we are all operating this kind of like, this is quite a comprehensive question, right? So it involves a lot of like aspects, and there are a lot of like things to unfold that I don't know whether I have time to unfold. No, don't be sorry at all. It's very interesting. I think like we have both something like a top-down and a bottom-up perspective in which we try to trade off our system by having something that is technically novel, but also something that is acceptable clinically for both clinicians, provider, and these are usually the stakeholders that I personally struggle a bit more to collaborate with, because of course, ultimately, for me, the translational aspect is just a part of what we do in the lab. Something that we find that we are currently doing in the lab that I personally find quite fascinating is the ability to, we've been working, and I think everyone to a different scale is working on this level of like adaptable controllers that is really intuitive and is looking at like individual underlying biomechanics. But I think since we're working with like large scale physical robots, we've been looking quite a lot and extensively into shaping also the direction optimization of the hardware design as well. So the morphology, and now we can co-adapt the morphology and co-optimize the morphology together with the controller with end users. And that has its own challenges, but it's quite fascinating and brings together a lot of like a wide audience, starting from like people from primary care, secondary care, of course, like clinicians, patients, and so on and so forth. So yeah, I will maybe pause there, but yeah.
Thank you very much. So probably a big problem is the control, translating the control in terms of the interaction, and it's mostly a cybernetic problem, actually. There is a discipline where we are never mentioning that is exactly the study of the feedback and the control. Danny?
Thanks, Jacinto. Again, a very broad question. I'll just focus on a specific aspect of my experience, I suppose. Yes, of course, it was difficult. We spoke different languages to start with, and it took me years to actually be able to communicate effectively with my colleagues on the clinical side. Over the years, we also built that culture in the lab, and after a while, it becomes more and more involved in rehabilitation robotics in the biomedical aspect. So we almost everyone has a clinical supervisor. Some of my PhD students are doctors. So after a while, it becomes easier because of the infrastructure that has been set up as well. Every single one of my PhD students these days would have to submit ethics applications. So that becomes part of the practice as well. And to do that, you have to talk the right language and all that. I once ran a very interesting course actually to improve the situation. 4 of us, 2 from engineering, 2 from physiotherapy, 4 professors, we came together and ran a class, and we co-teach the entire class together just for the summer. So it's an intensive class, and we lecture to everybody, and I sat along in every lecture. All four of us sat through every lecture. So if the clinician said something I don't understand, I go, I'm sorry, I don't understand that. Can you say it again? Can you explain it to me? And so that also showed the students that the lecturers don't understand it either. It's fine. So it became a very interesting subject. So we both departments taught it, and then we organized trips to the hospitals and all that. That really helped with the communication as well. I also learned quite a lot of things. Actually, I think I learned the most out of the people who were there. I don't know about the students, but I certainly learned a lot in that subject. But yeah, I think communication, just understanding, from all the way from the terminology to the kind of practice, the kind of culture, a lot of things are very different. So it took a while to get used to.
Thank you very much for such a response. You made me remember during Rehab Week 2022 in Rotterdam, when a medical doctor told me, first we need to trust you, then we will use your robots. So trust the engineer and the researcher before trusting the robot itself. Thank you very much. Veronica?
Yeah, thanks. And Danny, I really love what you said. It resonates a lot with me. It was already said, but I think it comes down a lot to that communication and really relationship building in the end. Yeah, just into also how you say, you need to build trust in each other. So we have to start speaking a language that all of us understand. And so the challenge is partially that in-depth knowledge that you really need in very different fields. Yeah. So for us, for example, big problem or big challenge is we really need that in-depth robotics and engineering. At the same time, we need a very good understanding biological, medical mechanisms, all that. So that's a big challenge, and there's not really that perfect program that educates a student in that, and that's okay. But that means we have to keep learning all the time. And then the other thing is about communication or terminology. For example, I see this all the time when people talk about a model, or I have this model that I use for this and that. And really, model means so many different things in different fields. Yeah, it could be a computational model, it could be an actual physical 3D printed model, or it could be an animal model or whatever. So a lot of times people talk about something and everybody has a different image in their head what that looks like. So it's important to communicate well and explain and ask questions too, and not be afraid to say, "Oh, I didn't understand this," without feeling stupid, but just honestly, just learning from each other on that.
Thank you very much, Veronica, especially considering that the linguistic issues in technical domains are quite challenging. Just consider that for describing the concept of the assist as needed in a context of neurorehabilitation, I used another one that is automation bias. That is more general, but it's closer to psychology itself. So it's exactly the effort we should do for communicating with experts from other fields. And it's better if we check the chat, but there is no question. But I asked the attendees if they have anything to ask to all speakers. Otherwise, they can send questions via email, as I will do later, because I have several questions for each one here.
I've got a specific one, just because the goal of this webinar is to foster collaboration with the UK and the other speakers countries. So I guess Letizia can jump in as well from your side, but mostly for the other two speakers, how do you find collaborating with the UK? Do you see any challenges? And what can we do? What can the UKRAS do to sort of foster and help this collaboration, and even meeting new people that sort of share your knowledge and share your expertise, and you would sort of, or even have tangential knowledge they can sort of use to your advantage. So yeah, have you got an experience, or what would you like to do to help you in foster those collaborations?
I think for Australia, I mean, UK is it's a very far, but at the same time, very close country. We have a lot of collaboration with the UK. I personally, I've worked with Etienne Burdett from Imperial for or for a while, for instance. Southampton, Andy, we should really get something up, work on something together. But I don't know an immediate answer to your question, actually, but there's already quite a fair bit of collaboration going on, but it would be fantastic to look into it and, get some opportunities to work together.
Yeah. If you think about anything, let us know. We're always here to
Yeah.
help. Veronica, how do you find it? Have you got any experiences yourself?
Oh yeah, I mean, I think relationships are very good. The key is always to find common funding, right? So that will really push things forward. I have good relationships with quite a few faculty members across UK. Yeah, I think a lot of times it comes down to, okay, for example, can we fund a project together, or students going one way or the other? I know Canada has also quite a few opportunities to fund, let's say, student exchange or research stays. So we have some programs that are really easy to access. So that's sometimes a good starting point as well. So yeah, I think there's lots of commonality.
Perfect. Letizia, have you any final comment on that?
Maybe super quickly, just funding from UKRAS. UKRAS is the government body that is enable us to get funding through mainly in the UK, but also there are schemes like EPSRC working with overseas scientists, for instance, right? And I think that scheme is really nice when there is a specific link with Australia, with Canada. I think like flagging those opportunities up from like a UKRAS perspective would be nice to, enable bilateral collaborations for sure.
Yeah, that's a good idea. Yeah.
So I think there are no more questions. I can say that I totally agree with Letizia, because the last overseas call of the PSRC, for instance, is focusing on several countries except for Canada and Australia. We really need a bridge with them. At least I personally need bridges because I have several friends in both countries. So thank you very much. Let's go on with the discussion via email or via chat. And thank you to all the attendees and the speakers. And see you. Thank you.
Thank you so
Thank you very
much.
much. Thank you for organizing.
See you later, everyone. Bye-bye.
Bye.